a very well-read textbook in 1976, Kaplan and Sadek, the major textbook for psychiatry people, at least in the US as well, but in Australia, said that the rate of incidence was about 1 in 1 million, and they were uncertain as to whether the effects were deleterious. I'm going to skip through the statistics because we've done them a bit today, and I want to move on to the patient story at the end, but I'll flick through them quite quickly. We know that rates of abuse are very high. People don't normally tell. The ACE study we've already talked about today. I have an issue with the headings that people use to talk about abuse. They talk about physical, verbal or emotional, sexual or neglect. I think they're all emotional. I think emotional should be up the top, and underneath we should have the subheadings. There are lots of children who've been notified in Australia. The cost is thought to be somewhere between $10 and $30 billion per year, the cost of child abuse in Australia. Almost all mental health patients have had some exposure to trauma. You've heard this. You've seen these numbers. I'll keep going. I will just mention one survey by Mullen that was done nearly 20 years ago. It was a community survey of a couple of thousand people in New Zealand. And although the numbers were very small, it showed that up to 85% of women who had been admitted to a psychiatric institution had been sexually abused before the age of 16. And the more severely sexually abused were admitted up to 16 times more frequently. And the suicidal behaviour is much more closely related to sexual abuse than it is to depression. Abused inpatients come in earlier, they stay longer, they get more medication, they get locked up more often. The rate of PTSD in Australia is about 1 in 80 people, 1.3%. If you look at inpatients, the records on the charts don't show PTSD very frequently. In this study in America done in 1998, 43% of inpatients and outpatients had PTSD, only 2% had this diagnosis recorded on the chart. That's perhaps at the high end, but we know that these things occur very frequently. Muse felt that the comorbidity of PTSD was often missed, but as we've heard before today, Hodis, one of the American writers, has said many providers may assume that abuse experiences are additional problems for the person rather than the central problem. It might be safe to presume that anybody seen in an inpatient psychiatric ward may have been abused. We've heard this before, and to treat them as such. And this is a concept of universal precaution which is used elsewhere. Again, I'll skip through these very quickly. You've seen them all before. Childhood abuse causes all sorts of problems, physical problems, social problems. Actually related to increases in heart disease and cancer, we know this. Every psychiatric condition can be related to childhood abuse. There are even now textbooks about the relationship of childhood abuse and psychosis. I won't go into that any further. Lenore Turrider wrote a very important article in 1991 about the effects of childhood abuse. She talked about type 1 and type 2, and generally type 2 are more important because these are the things that happen over and over again, and she talked about the subsequent unfolding of horrors creating a sense of anticipation. And this leads to a major attempts at psychological self-defence via denial and psychic numbing, self-hypnosis and dissociation. And Van der Kolk has tried to turn this into a category for DSM-5 called developmental trauma disorder. Van der Kolk also said that PTSD is not very good for adults who've been abused. It doesn't take into account the affect dysregulation is one of the biggest problems. Lots of people have written about post-abuse syndromes. We've heard about rape trauma syndromes before. Galinas wrote an incest recognition profile again 30 years ago, and we talk about dissociation again, floating near the ceiling and looking at what was happening. And in papers that I don't think that are quoted very often, a social worker in 1985 wrote that patients who've been abused in childhood can also appear to be quite psychotic. We know that people who've been abused have distortions in their peripheral vision, they hear sounds, but what is probably less recognised is that those, he says, those who've suffered more severe abuse could also hear more elaborate voices, persecutory voices. These are often, I think, mistaken for schizophrenia. We've heard about Judith Herman's concept of complex PTSD. She said that the lack of an accurate diagnostic category has serious consequences, that the connection between the symptoms and the abuse are often lost, and the responses by the medical system often replicate those of the abusive family. You can sneak complex PTSD into DSM under DESNOS, but it doesn't really have its own category, and these are the sorts of things that we see. People who've been abused have problems with affect regulation, memory, dissociation, self-loathing, difficult relationships. I'm not going to talk about the neuroscience at all, other than to say that there's a big band of tissue between the left and the right hemisphere called the corpus callosum, and we know that that's much smaller in people who've been abused, and that increases the separation of the hemispheres, which is a difficult problem. Van der Kolk again says, traumatic experiences persist primarily as implicit behavioural and somatic memories, and only secondarily as vague, overgeneral, fragmented, incomplete and disorganised narratives. And he's talking about adults, not children, where it's even more complicated. They are not usually available in the form of an autobiographical narrative, and seemingly unattached to other experiences, are stored as images, sensations and emotions in the right brain. And if you look at neuroimaging studies of adults who've had PTSD, who are re-exposed to the trauma by having been read a narrative that's individualised to their own trauma, you see that the left brain has hypoperfusion, the right brain has hypoperfusion, and as the left hemisphere is usually dominant, the one with Broca's area in it, there is more emotional than linguistic processing, and the failure of the left hemisphere is especially important, as it doesn't tell the sufferer that the memory doesn't belong to the present. The sufferer goes back into the past, and they're there in it at the time. That's for adults. For adults who've had adult injuries, traumas, for adults who've had childhood traumas, more complex again. Finish off with a quick vignette. Again, a little warning. I've given this story before in a longer version, and it can sometimes be distressing. I hope you find it helpful. Susie was in the public mental health service. Susie is a heavily de-identified person. She was in the public mental health service for about 25 years. She was first seen in the child psychiatry service with behavioural problems. She later spent time in juvenile detention facilities, drug and alcohol, and then to the adult mental health service. She had problems with affect regulation, thought to be angry, violent, attention-seeking. But it was also noted early on that she needed to block out emotional pain. She suffered with nightmares and she overdosed. And retrospectively, as an adult, she added that she was always anxious, she'd never felt good about herself, and she had major difficulties in relationships. She first presented with psychotic symptoms 3 months after giving birth to a daughter. She suffered the voices of cartoon characters and barking dogs, and she described these as being put into her head by her daughter. I reviewed the file and wrote the case up, wrote the story up. 8 consecutive psychiatrists had diagnosed her with schizophrenia. Eventually, left wing's not the right word, a very brave therapist started to talk to her. I was a psychiatrist and I worked with a therapist with Susie for about 4 years, about 15 years ago. And it soon became clear that Susie had been systematically and ritually sexually abused by a stepfather and by others. That her mother was unable to do anything about this, she hadn't been able to protect her, and that her abuse history had in fact been detected quite a lot earlier during her drug and alcohol treatment. The therapist sat with her probably 300 or 400 times. The voices of the cartoon characters that she heard were eventually recognised as a particular favourite that she watched on TV after school. She dissociated to the protective character whilst being abused and later experienced this as a voice. And the barking dogs that the baby put into her head, she similarly recognised as a real noise that she had dissociated to whilst being abused before. Over 4 years, her therapy progressed. She was on oral, intramuscular antipsychotics, antidepressants, mood stabilisers, benzodiazepines. These were all withdrawn and she was discharged. Now, I work as a general psychiatrist and I see a lot of people with schizophrenia. Susie is not a good example of the patients that I see. But the lesson that I learnt from that was about listening, trying to put symptoms into context, which it can't be said enough, and always considering the role that trauma might play. Susie did not have schizophrenia, but that's the only lens that the psychiatrist could see her through. She was subjected to ongoing abuse and she couldn't escape. She couldn't regulate her feelings. She didn't value herself. She had complex relationships with others. She had no idea that her symptoms were related to things that had happened many, many years before. Childhood sexual abuse has, of course, much broader effects than the abuse itself. It can usually only occur in an atmosphere that's not protective. That's not always. Of course, the harm is attributable to the age and the frequency and the relationship of the abuser to the betrayed, and the betrayal, or again, the lack of respect. And I think this is the ultimate in relation to lack of respect. For Susie, there was not likely to be any normal attachment, no normal development of a right hemisphere, no possibility to regulate her own affect, no one listening to her, being with her or nourishing her. And the repair only occurred when the therapist was brave enough to get beyond the symptoms and listen to the story. When she really listened and she really joined with Susie. When she tried to reflect back her understanding of what had happened, and when she sat with the pain and looked for positives. Notwithstanding significant biological contributions to some mental illnesses, we're all put together in the context of others. Histories of trauma and abuse are very common. We've heard this over and over again, and we've only been here since 9 o'clock. These histories may not be relevant. They may be partially relevant, but in some cases they may be totally explanatory. Identifying the trauma allows not only for its relevance to be understood, it allows for the patient to be heard, sometimes for the very first time, and it may point to a completely different treatment pathway. Thank
you. Richard, thank you for that. Wonderful hearing from a psychiatrist who understands and who listens and who hears. Do we have any time for questions? Maybe just one if we... do you want to go back to the microphone? Or? Oh, should we?
Yes, I see psychotherapy as a form of neuroplasticity. Absolutely, I think we generate new pathways. I sometimes couch that in those terms for some people that I'm seeing in therapy as well, absolutely. There is some preliminary evidence that we do get more right orbitofrontal blood flow with some forms of psychotherapy. It's not particularly sophisticated at this point of time, as far as I know.
Okay, let's all thank Richard. Thanks so much.